Looks like everybody's still finishing up their clinics. Hi, everybody. Good afternoon. We'll just wait a few minutes to let a few more people join us before we start. Everyone's very quiet today.
Morning, or is it afternoon now, aren't we?
It's afternoon. Hi, Karen.
Hi, Arvana. Hi, Steph. Hi, Jenny. Oh, everyone's getting there
Everyone's
slowly.
quiet.
Yeah.
I'll just wait a few more minutes and then we can start. If that's all right, Karen.
Yeah, gosh, yes. No. I don't know, is Marie with us yet? We're still coming in, aren't they?
Oh, yes, Marie.
Hello,
yeah.
I'm
Hi,
here.
Marie.
Hi, Marie.
Hi.
Oh, here's some more smiley faces. Hi, Rima. Hi, Tammy.
Hi, everyone. Hi. Hello, everybody.
How are you in the Arctic?
Yeah, looks like it. I know. No, I'm in Stevenage actually, which could be almost similar. No, I'm just
Like the heating's not working indoors or something.
Tell me about it. I know. I'm going to the Arctic because I've got a visit this afternoon up to Newcastle, where my son is at university. So I'm heading up that way. Hence why I'm in the car. But I'll take the camera off in a sec, so you have to look at the full fleece version.
Yeah, that's funny.
Hi, Mohammed. Okay, shall we start? Good afternoon, everybody, and good afternoon to our November meeting. This is actually our last meeting of the year. The years whiz by quickly, and we've all been working very hard, and there's lots to show for it as well. We've got a really good agenda today. We've got 4 items on the agenda. If I can just remind everybody to keep their microphones off unless you're speaking. Could we have hands up or questions in the chat bar? And this meeting is being recorded. So the first item on the agenda is Karen just running through our AGM. Thank you to those of you that did attend. Karen will just be giving us a bit of an update on what was discussed at that time. Okay, Karen. Karen, you're on mute.
Sorry, I said thank you, Arpana. And if you'll forgive me, I'm going to take it off camera because I'm on the phone in a car. But hopefully I'll still be able to whip you through. And I'm going to do a real fast whistle stop to just share with people where we got to in terms of the update at the AGM. So just in front of you at the moment, we've just got the sort of summary of the position in terms of what we were able to deliver across the borough, and you'll see that we were able to deliver nearly 200,000 appointments across the borough, and obviously this is in addition to the services that you all provide in primary care. But hopefully it's evidence of the additional support that we're able to bring, and we've grown significantly in size because we had to grow our staff in order to be able to deliver all those services. So you can see the organisational growth that we saw as well. If we just move on to the next slide, Maggie, it's really just a quick reminder of the range of services that we provide, and obviously most of you know we we did support the 7-day access and now the extended access service, obviously deliver a full range of vaccine services, but also increasingly offer services on a sort of broader basis in terms of home monitoring and the long COVID support. If we just move on, we were also able to grow the range of direct support to practices. So you'll know, I think some of you have had some specific support around CQC assessment, doing mock inspections and some of our hygiene inspections. But also most of you will know that we've been able to secure Clarity Teamnet for all the practices across the borough, and just a bit later on in this session Kenny's going to walk you through some ideas on how we're building on that to develop the support for practices. If we just move on to the next one, I think one of the areas we're particularly keen to build on is our leadership around primary care, and Marie's here today, so it's really important that we can show how strong the voice in primary care is in Newham, and we've worked obviously closely with the primary care networks and also the LMC and colleagues to bring as much coherence to the voice in primary care, and things like this webinar are a key part of how we do that sort of coordination and support across the whole system. And then just the last two bits, we have, if we just move on to the next slide, Maggie, a range of services that we work closely with our PCN networks on. Many of you know we provide sort of admin and finance and HR support to the PCNs, and I think that's helping a lot of them to bring greater stability and greater support to the various practices needs, and giving us best opportunity to take advantage of the additional roles that sit in primary care. If we move on to the next slide, the final thing really is just to say within the organisation we've grown our organisation to be able to support all those changes, and we've seen growth in number of staff and leadership, and it was particularly pleasing to us over the summer when we did a staff survey to be able to see that the staff are really proud of the fact that they work for NHC, they enjoy working at NHC, and something we've really majored on, which is our dedication to diversity and inclusiveness. And it's quite amazing to me that 100% of our staff do see that NHC is an organisation that's committed to those values. So it's something we've worked quite hard on, and it's something we're going to continue on a journey with, but also pleasing to be able to share that with you. And then very finally, obviously all of that work has enabled us to have a stronger financial position, and you'll know that in the course of building that stronger financial position, it's enabled us to invest in the practices and create the support that we can offer to the practices. So we've got a strong investment program that we're building our offer around practice support, but also bringing a lot more support to the primary care network. So hopefully all of that information is broadly familiar to you, but just a quick synopsis there. And then if I just go to the very final one, we are inviting you to tell us more about what we're doing and what you want us to do. So I know some colleagues have been talking about could we support Ardens, others have been talking about can we do more for health and safety services and so on. If you could respond to our request, one, you might stand a chance to win the tablet, but also it helps us make sure that we are able to invest in the services that you want going forward. So that's a whistle stop from me, but hopefully anyone, if you've got questions, then please do fire them directly to me by email or in all the other forums that we've got, because I want to give you maximum time to talk to Marie.
Thanks, Karen. Thanks. And I know Karen had members of the team send out the booklet from the AGM, so practices have been sent that information. But if you would like a copy, please do drop us an email so we can send that out to you if you want any other copies. Right. So next on the agenda is Marie. Marie, thank you.
Somebody's hand is on.
Sorry. Oh, okay. Wax, just quickly.
Yeah, very quickly, just wanted to go on record and say a big thanks to NHC and the team. Marie's here, and Marie, we've shared the NHC AGM meeting notes with Richard Meddings, the chair of NHS England, and all comments were that it was very, very well received. Going back to the AGM, there were two other big areas, and you've touched on one of them. Workforce you've touched on, but I think we need to do a lot more in that immediate kind of situation from a Newham perspective. We now have moved into red from when it comes to practice nurses and GPs. And then the other thing is about estate. Marie, we're all in broom cupboards at the moment, or we're either at home. We've really got no space. But I know NHC have got are starting to move forward with that conversation as well. So just a big thank you to NHC for all the great work that you're doing, and really hope that we continue to build that relationship and services start to become even better for our patients of Newham. Thank you.
Thanks, Wax. Okay, so Marie, you've been working for over, I think, 20 years in Newham as a leader in various roles. Just a few things that I would like to mention about Marie. So she was recognised in 2010 for her contribution to the Borough of Newham when she was awarded the honorary freedom of the borough. In 2018, she was awarded her CBE for Queen's Birthday Honours. So this is all fantastic. And then my particular favourite, you were named as one of the 80 most influential people in the NHS in 2020. And I also hope you don't mind me mentioning that you are also a local resident and a patient, but today you're here with us in your role as the chair of the NEL ICS. So thank you, Marie, for joining us, and over to you. And I can see there's lots of love for you.
Thank you. And I think I can't separate out the professional role and my role as a resident and a patient, and all those things that you talked about are nothing compared to what you do every day for the residents of Newham. So I'm really humbled, and I truly do believe that primary care is the bedrock of the NHS and health services, and the biggest advocate, and actually not just for you, but actually with you to understand, because you're the ones who feel it and know it, as we say in the Caribbean. So I don't know where people are, so I thought I would just say a bit about what the ICS is and what the expectation is and what we're doing in now. I've got a question for Jim. Of course, I'd get a question from Jim that I'm going to try and answer. And then happy to have an open discussion and also to take things away. And I just wanted to say to Wax that Richard Meddings from NHS England, he's the chair, so Amanda Pritchard's boss, was really impressed when he came round, and we were the first area that and all the visits he's been on that said just talk to frontline staff and see what it's like, and the conversation was respectful but challenging, and he appreciated that so much that he's coming back again, unfortunately during the same time as the Fuller launch, but that was the only day and he wanted to come back really quickly. So I just want to thank you for that. So what is an ICS? I think most people will know, basically it's a partnership between all the organisations, including primary care, that meet the health and care needs of a population. And in North East London, that includes the population from the city out to Havering. We've got a budget of approaching 4 billion. If you add in everybody's, like local government, you're probably approaching 6 billion. So more than the budget of a small country. And we've got a population, particularly with its growth, that will reach the size of Wales population. So we're quite enormous in what we're doing. It's about how do we use all that resource and expertise to provide the best outcomes for our residents. And so we've got 4 aims as integrated care systems. So as a partnership, we want to sustainably plan, coordinate, integrate, transform, and innovatively work with our people and communities to improve outcomes in population health and healthcare. We want to tackle inequalities in access to experience of and outcomes from health services, enhance productivity and value for money, and help the NHS to support broader social and economic development. So those are 4 aims with which we were established for. And we're a statutory body now. We're an integrated care board, and we're actually accountable for the North East London NHS funding. And actually, we're actually quite a major change in how health and care services are planned, but also paid for and delivered. So quite a key aspect of this is to move away from competition and actually have that focus on mutual accountability and collaboration. So looking at how together we need to improve system performance and system outcomes rather than focusing on the individual organisation accountability as we did before with competition. And I just wanted to say that provider collaboratives are a significant part of this new architecture. And when we were first being established, they talked about how NHS providers such as Trust are expected to be in provider collaboratives. And in North East London, we were pioneering in establishing a primary care provider collaborative, primarily to ensure a strong voice for primary care, but also a way for primary care to ensure system-wide leadership and local transformation and engagement. So that's really important, and now it's sort of talked about in the Fuller review. I think you know that we operate at neighbourhoods, which is really important, and at place and at system. So working across each of those elements in a matrix way, and we're still trying to work through this, but subsidiarity is you know a defining principle. So we want to make sure that we transform services, integrate care, and tackle inequality as close as possible to where people are and where most care is delivered by yourselves. So we've done loads of work. We've as a whole community thinking about what's our purpose and what we should be focusing on. So we've devised with our people communities a purpose, which is that we will work with and for all the people of North East London to create meaningful improvements in health, wellbeing and equity. And we've got some design principles, you know, so that subsidiary point, but actually it's also that we're only working together because we want to improve quality and outcomes and secure greater equity and greater value. And that everything we do should deepen collaboration. And we've got 4 flagship priorities. We have to develop and deliver this integrated care plan by January, and within that we've got these 4 priorities we've agreed together. Primary care, you know, are integral to each. So one is babies, children, young people. The second is mental health. The third, employment and workforce. That's both about creating meaningful work opportunities for people who are residents in North East London to come into the NHS, but also actually for those of us who work in NHS to actually have a good work experience. And the fourth one is long-term conditions with a focus on prevention. And I think what's really important is to think about what this might mean for you as clinicians, and what the expectation is. And I think this is particularly important for thinking about the relationship between primary and secondary care clinicians, is that we need you to provide your leadership to integrated care system. And actually, the expectation is that organisations will move outside of their usual boundaries to become clinical system leaders. And each ICS must have in place mechanisms to support and enable clinical leadership within each of those layers: place, neighbourhood and system. And there's some specific guidance that sets out expectations around that leadership, including making sure there's diversity of involvement in system decision making at all levels, enabling shared learning and supporting clinical innovation, and creating actually a wider support offer for you as clinicians to do this work. And of course, we know there is the fuller review, which has some very clear expectations for the integrated care system in relation to primary care. And that includes developing a system approach to supporting the integration of primary and urgent care, and that including NHS 111, enabling the evolution of primary care networks into neighbourhood teams, embedding primary care workforce as an integral part of system thinking, planning and delivery, and as Wax was saying, establishing a plan for estates, but also, I think, for primary care sustainability, and that we need to work alongside our residents and communities to do that. And you'll be aware that there's a major launch at West Ham Football Ground, and if Jake and John was here, we'd be going yay for West Ham on the 29th of this month, to look at actually how can we make sure we deliver the recommendations of Fuller within North East London. The other thing that that Jim did, he made me read a really long document because he asked me what my views were on the sort of the health and social care committee's report on the future general practice. And this is my personal view after reading it, rather than an ICS view, because I haven't asked anybody, which is a bit, it is a usual thing for me. So I think overall the report is a welcome intervention. I'm looking at my notes now, to the policy and political narrative surrounding general practice, and I don't think that political narrative has actually always been helpful. So it's really good that that the report is challenging that, and I think it's important, particularly following the Fuller review and the work that the Royal College of GP's been doing on the future of primary care. It's right that there's a recognition that there is a crisis in general practice, not one of its own making, and actually spell out some of the actions that need to happen to increase the GP workforce and make a career in general practice much more appealing, particularly through freeing up GP time by sort of really decreasing the actual administrative task and the regulatory stuff that you have to do. And the people that Wax convened were really loud and clear about that when they spoke to Richard Meddings. I think it's also good because it talks about looking at funding mechanisms that will enable the NHS or ensure the NHS invests more in primary care. We still have the situation where there's the funding of trust compared to primary care is not appropriate. And actually, and to use this money to reduce the number of areas which are being under doctors. I like the bit about reforming pensions and exploring models to limit GP partners' personal risk, and and that recommitment to GP partners, I think, is really important. And it also, you know, it looks at the overemphasis on access, and how we have to balance that with the continuity of care, which you do every day. And that we need to look at how we measure continuity just as much as we measure access. So I particularly like the recognition of primary care networks within that document. And I think, you know, we need to do more to enable PCNs to reach their potential and have that meaningful impact on sustainability of general practice. And actually, if you ask me, and I would say this to the government, they need to commit to PCNs before 2024 and adopt some recommendations around reducing the administrative burden on them, and really think about how you incentivise collaboration to produce efficiencies. And I think we need to consider how ICSs can create the environment for PCNs to flourish. And I don't know much about that, but as I said before, who feels it knows it. So I'm looking to PCNs to be telling us what that should look like. I think the other thing, which I don't think it picks up as much, is that access is not a purely primary care challenge. It's actually a system-wide challenge, and there needs to be system-wide solutions. And particularly, one of my things that I'm championing at the moment, and will continue to do so, is better coordination between primary and secondary care. And there was this doctor called Ashwin Shah years and years ago, when I was a NED at Newham General, as it was called then, who was saying about how that relationship between primary and secondary care clinicians needs to be improved so that it can better support general practice. I keep trying, and I'm going to continue, and I'm in a better position now to make that happen. And I think that how we support PCNs, primary care, and develop those solutions should be a key part of what we discuss at the fuller review meeting on the 29th of November, particularly because you know more than me what the solutions should be. But I've actually flagged that with Paul Galuli, our Chief Medical Officer, and Zena as our Chief Exec, that we shouldn't just focus on the fuller review, but we should also focus on this report and also the plan produced by the RCGP as well. So that was all I was going to say, and I was going to open out to questions. I hope that was helpful.
Thanks so much, Marie. Does anybody want to ask Marie anything? Okay, we've got a hand. Manuel.
Hi, Mary, and thank you for that summary on the integration, ICB and the integration. One of my concern is we did know that during the COVID, how the digital transformation happened so rapidly. And one of the issues that the general practices actually face is the integration of different IT systems. They lag behind. So that actually creates additional administrative overburden. And you talked about the relationship with primary care and secondary care, and also that integration is also one of the reasons for that relationship. So I just want to kind of raise that, and what your thoughts on that, and what is the ICB going to do regarding that?
Right, so digital isn't my area of expertise. But I know that it needs to work properly. We're able to access care, and as a patient, which is always my fallback position, which I know is probably not helpful, actually access to digital care and have that increase during COVID and is being maintained is brilliant. But I understand, and it was a GP that taught me about interoperability. I can't even say the word, but so I know that we're developing a digital strategy. Henry Black is leading on that, and that making sure that the different bits can speak together well, but also thinking about how we can build on innovation of others and innovation for our population, for example, are over 53% Black minority ethnic, is really important. I think that's something that we need to raise on the 29th and make a priority for the ICS, and think about how we can support that and also fund it, if I'm really honest. I think it's also part of the challenge that we give back to region and NHSE as they want to implement the fuller review, that this is an area of focus for investment. And when they're thinking about estates and digital, they think beyond the hospital, and they think actually about primary care. So part of my job is advocating upwards and making demands there. I know I haven't given you the whole answer, but I hope that's enough. And I will take this back to the ICS. I'm taking notes as we speak. I think Wax has got his hand up. Is that Wax?
Wax.
Hi Marie, I've put the two questions in the chat bar as well for the record as well. For the first one is, so quality and performance, you've talked about, is a massive part of sustainability, right? So, mock visits, webinars, standard support is something, support for practices. Can we start a NEL program focusing on primary care quality improvement, which supports primary care and something that works for patients? I'll give you an example. So Marie, you came around and you saw stuff that happens at the practice, but CQC are monitoring us on Ardens. It's a specific issue, but they're monitoring us in a certain way, but we're doing something completely different. That kind of thing for me is labor intensive, is bureaucratic, etc., and all of that kind of stuff. And that's the kind of red tape that we need to cut. But where in the ICB do we have a program that solely focuses against supporting those hundreds of practices and the practices in Newham with that, and ultimately, where is the accountability line? Because there's a hell of a lot of work to do, especially when the regulatory model changes. And as you know, we live and die by the CQC sword, as it were. And the second question was, can you just give us a little bit of an update on the primary care medical director recruitment? Conscious that there's colleagues on the call and stuff like that, but something for us as practices to understand what the plan is going forward. We know about the triumph of patient, clinician and management, and maybe able to touch on the process around that and some timeframes. Thank you.
Marie, you're on mute.
Thanks, Wax. I'll strive to be polite about the CQC and how they need to make their inspection regime more tailored to reality of the current context, and how we operate. And so I know that this is something that NHS England and a previous health minister, I think the one before Sir Javid, were very interested in, is about cutting the red tape and the burden of filling in all those bits of paper that we don't really need to fill in. So that part of regulation is looking at this. I've not managed to have that same kind of dialogue with the CQC, who seem very dependent on lots and lots of bits of paper. But maybe that's something I can help with. Maybe I can link up with Karen and we can try and see whether or not we can get the CQC to come and present and to hear directly from primary care, because part of what we need to do is influence. So I think let's do that. I've seen it from the other side, and it's even the gathering of that information doesn't help us to be better. So I think that's important. So in terms of the primary care, I think the title is Associate Medical Director recruitment. There's been a bit of, so what we've been doing at the moment as an integrated care body part of the ICS is trying to, we're going through kind of like a senior restructuring, and as part of that, we're actually saying we need to have an associate director, a medical director for primary care. That rests with Paul Galuli, as I was talking about before. And what I need to do is get the timescales and timeline from him, Wax, because I don't know it off the top of my head. I'm really sorry, but I promise faithfully that I'll find out today and I'll send an email back so we can share that information. Thank you.
Thanks, Marita. I think your suggestion of the meeting with the CQC is well received. Karen said that she's happy to meet up with you to look into arranging that, and Laura's also suggested that it is a great idea because it will allow them to understand what we're doing locally and the pressures that we have locally. There was another hand up, Fazana.
Thanks, Arpana. Hi, Marie. Thanks, Arpana. Mine was really more just a comment and a thank you. Just to say that I can say this to Manuel, he's my PCN manager. Just to say that nationally, actually, with our East London patient records, we are one of the most progressive ICSs, and in fact One London is with One London record. Not everybody can see hospital appointments and especially hospital blood test results, so that really helps. Love to see more progress on that, but we are very ahead. And Marie, I wanted to say thank you. You listed 4 priorities for the ICS, the first 2 being mental health and children and young people. I wanted to say a massive thank you for your support in Newham Central One's reduction in knife crime project, because that hits 2 if not 3 of the priorities. And again, we are nationally recognised for this work, which has been on top of the IIF and the DARES, and looking forward to your continuing support. But just to say there's some great work going on, and that couldn't happen without the support of the ICS. So it's not all doom and gloom and regulation. So thank you. Thanks, everybody.
My job is just to support incredible work for Zana, so in any way that I can. So very happy about to be able to just have to give a helping hand, to be honest. And Fazana and Wax and others know you just have to send me an email and I'll try and do something about it. Thank you.
Thank you, Marie.
Okay, there's a question from Helen. Helen, do you want to say your question, or would you like me to read it out?
It was really about what other things would you like us to help with to influence some of the decision making, both at a national level and local level. I know that we have significant impact when people come and visit and recognise some of the work that's happening, but I wonder how else we can encourage a sense of urgency around some of the transformation that seems to be missing at the moment for me.
Thanks, Helen. I think one of the things that's really important for me is that we have a quite clear ask, particularly of London region, about what we need in primary care. So so not pages of stuff, but just saying to them, you need to do these, sort of 5 to 6 things that will really make a difference. So I mean, I don't know what they would be, and maybe that's a conversation that you can have, and then you can provide those to me, and I'll just talk to the people at London region and also the people nationally to push down onto London as things that we would need to do to create that change in primary care really rapidly. So I know there's some practical things I'm still trying to sort for you, Helen, and it was really good that you brought it up when Richard was there, because he didn't realise the foolishness that was going on. But I also went back to Zena and said, we need to make some decisions and we need to make them quickly. So anything you can tell me, but if we can have 6 key asks, that'd be really, really great. Thank you.
Greg?
Yeah, hi, Marie. First of all, it's really refreshing to hear your update, and everything you've said is music to my ears. You talk about retention, capacity, demand, workforce, estates, all of the things we know are a challenge. But what I think is really important is your very clear message that this is about a system response to a system challenge, with general practice as the bedrock in the centre of that. And I think it's really important that we kind of hold on to that. This is not about alleviating pressure on EDs or A&E. It's on the whole system. And I'm really glad to hear you saying that. It's also really refreshing to hear you talk about leadership. You know, I think this is a challenge for all of us. We're talking about changing embedded behaviour, culture, and, you know, actually working together to enable and support a system change in thinking, rhetoric, messaging, all of those things. So all of that is really positive. The only kind of thing I would kind of urge is when we talk about developing PCNs, you know, beyond 2024, I agree we need to think about, you know, what happens next. But my kind of sense is it's about thinking about GPs working collectively, collaboratively as groups of GPs, you know, rather than focus being on the DES. And if we can get our heads around that in a more kind of systematic way, I think that's going to be really positive for Newham. Final point is, yes, the ICB, but we need to maintain the Newham voice and the Newham identity, and, you know, reflect the Newham priorities in everything we do. But thank you again.
So we're agreeing lots with each other, and of course I have a selfish reason for agreeing, and all the Newham voice should be strong within that, and that's why to me place is much more important than system, and local, even within that, local is more important than system too. So so, you know, although I'm obviously have a preference for Newham, I think that's the truth for each of our places, each of our boroughs, that we really need to retain what's happening locally, and that should be our driver for change and transformation, not top down. And part of my job is trying to tell NHSE to stop sending out loads and loads of guidance that's not really helpful at all, and it can't be done top down because it won't happen. And actually I've always believed that the way in which it operate is resident driven, clinically led and management enabled. And that's one of my biggest challenges actually as I've come into the ICS ICB, is to say it has to be, to work, it has to be clinical leadership. And after all, I'm not being mean, but you've costed a lot of money to educate. You're our most intelligent people, because it's hard, apparently, really hard to get into medical school. So we need to really use you as a resource to do innovation and to enable this transformation and to make a difference for our residents.
Rima?
Thanks, Arpana, and again, thank you, Marie, for coming today and talking to all the GPs. I think it's so impactful. I guess from my perspective, I'm going to be thinking more about the partnership and where we're going with that. And I think with the integrated care system, I think it's just a matter of how we're thinking and progressing is quite different to how we have done before. And we had a really good session with the GPs in one of our PLT sessions to start to talk about neighbourhoods and start to think about what the impact is on our residents, and actually is this going to create a better outcome for our residents. And it's starting to think about that, which can be quite difficult in primary care, because we're sort of just set in our daily jobs just trying to deal and literally treading water and just getting through the day, and rather than actually having the space and time to think about actually what is the future, what can make our lives easier, what's actually better outcome for the resident. But I guess for me it's about inequity, and for Newham we are one of 7, and what more can we do to basically press on the ICB to say, actually, you know, Newham is an area where we are expecting a huge population growth, more than any other borough in Newham, within the ICS, and what more can we do to kind of, I guess, have that connectivity with the ICB as a whole, not only just primary care, but as a system, to sort of just continuously put that kind of pressure on to say, actually, we are here. We do need as much resource as anyone else for our residents, because I think we're all sort of struggling to articulate that at the moment.
So I think it's, you know, when you're trying to influence and persuade people that their priority should be within any specific area, the thing is to sort of align up to what their purpose is. So I think, you know, so that the whole, you know, so if you look at the purpose of ICSs, 3 out of the 4, and I would argue even the money, is actually about tackling health inequalities and improving outcomes for our populations. So I think the way in which you proactively identify and target communities who can benefit from, you know, health, you know, sort of interventions, particularly in those 4 priority areas, will seize our imagination. I think the work that Fuller said around PCNs and basically primary care leading or evolving into integrated kind of like neighbourhood teams is going to be quite important as the basin through which we will actively make changes happen. I think it's about inviting people in to see. So it's wonderful that I've been invited, but in a sense you're preaching to the converted, and there's so many people on this call that's got a direct line to me, that actually inviting Zena, which I know Karen's on to doing, but also Paul Galuli to come and talk to you, I think is really important. I know I would invite Henry as well, because he looks after the money and he's doing the estates and he's doing the digital. So I'd invite Henry to come and have a conversation. So what you're doing is you're influencing the most senior people, and you've got Diane, who's the chief nurse as well. So I would say have a dialogue with more of the people that are going to be coordinating decisions, not taking the decisions. And we've already got a commitment that we need to sort of address unfair balances in allocations as well. So I think that's important. Yeah, thanks.
Hammy?
Thanks, Upna. Hi, Marie. So thank you for your candour around the fact that actually we're really quite expensive and actually quite a limited resource, and that we need to be, sort of have our voice in the system, but it does need to be a voice that isn't constantly drowned or bottlenecked by inappropriate requests of us. So I suppose, for me, that's about utilising the team. And if this is as Greg rightly said, we want a system response, because it's, the challenges affect all of us. I think that needs to be kind of front and centre. My second point was around the expectation of our clinical sort of leaders working sort of beyond how they've worked before, working differently. And one of the challenges has always been about having good leaders, but how do we actually get stuff done? And next step. So refreshing to hear that you're giving us the names of who we should be sort of trying to, sort of influence and get to know. But I also think for the leaders on the ground, I'm just really keen to hear, what support structure we're going to put in place to, one, keep them in role, but also to encourage as us as the Newham system to kind of build that legacy and to encourage talent into our borough. Now I know that's part of the kind of tick box that we said, but it's actually how we're going to make those next steps happen that I just wonder if you've got any ideas about.
So I would start from the fact that there's a requirement on ICSs to ensure that clinical leadership is supported. So if I take you back to how we were established, there's some really clear guidelines about how we need to, and we will be judged on ourselves as integrated care systems, how we're enabling a full range of clinical and professional leaders from a diverse background to be part of integrated into sort of system decision making at all levels and supported with a flow of appropriate information. I think there's stuff around nurturing that culture that was spoken about before, but actually a culture that's also about shared learning and supporting you to innovate. And I think that also means creating a support offer that's wider than training and development and giving you some money to do some more things. I think it's actually it's about those development opportunities, but it's actually that ability to release you, so you've got some time to think about it, so you can't see that in isolation. One of the other things that I do is that I work with the Local Government Association and the NHS Confederation as a peer associate, and I went down to Gloucestershire, and they've been having a really good dialogue about how do they make that guidance a reality, so clinicians can be supported to be leaders, and actually how you hold the ICS to account for that you know, that commitment that we must have. And I'm quite happy to share the information from Gloucestershire, but I think that's one of the asks of Paul, and I can actually say at the board, we've got a board meeting at the end of November, I shall ask that our next board meeting, which is in January, that we have something on, you know, that is actually presented on clinical leadership, and I shall recommend that they should have a GP that presents alongside from the ground. So Jagan and Mark are there, but you know, maybe you're putting your hand up, Tammy, to say that you'll be there and you'll present to the ICB board about what we should be doing more of. I'm getting my own back. She's my doctor actually, so I'll get my own back a bit. So yeah, so I'll go back and say that Tammy will present alongside Paul on that. Is that all right?
I brought it up, so I've put myself on the chopping block. Thanks, Marie.
Brilliant, thank you.
Thanks both, and Tammy, we look forward to hearing back about the outcome of that. But I think that's a really positive step. Marie, Karen is asking, and I think this is something that we're all thinking about, is the population growth that we're already having, and that's, you know, that's exponentially rising. There's lots of pressures because of that in primary care, secondary care. There's pressures all over. What's NEL planning for this population growth that we're expecting?
That's a really good question, because we talk about it all the time, and it is Newham and Barking and Dagenham that are going to be impacted most, and Tower Hamlets a little bit, but it's mainly Newham and Barking and Dagenham. So we talk about it a lot, and we talk about how we need to change how we do things and how we need to lobby to make sure we've got the resources, and it's integral to lots of discussions. But I don't think that we've got to the point of having a cohesive strategy, if I'm really, really honest with you. So yeah, that's something. I'm sorry I haven't got all the answers, but that's definitely something else I'll take back. So what is, you know, and we've talked about, you know, how we can shift allocations over time so we don't destabilise the acute sector and all those things. But in terms of a really clear narrative about what we're going to do, I think we need that. Thanks for that question.
Joe?
Yeah, hi. People
Hiya.
may not know me, but I'm Jo Fraser-Wise, and I'm now acting delivery director in a job share for Newham. So you may have known John Rook previously, and I worked for John, but I'm now acting up into that. And just on the population health growth, Marie is right. It's from a NEL perspective. There is some activity, but we held a workshop to start this process in Newham and in conversation with NEL to really start developing the actions, and we're really keen to hold an open round table event with the breadth of stakeholders that we've got across Newham. So I will certainly make sure people are kept aware of that, but we know that this is a really pressing issue, and we want to make sure that we have a plan, that we have a vision, and that everybody's involved in designing and developing that.
Great,
Thanks.
that's great to hear. Thanks, Joe.
Hello, Joe. Just wanted to say that John never hesitated picking up the phone or sending me an email, so I'm sure that you're going to follow in the same way.
Definitely, Marie.
Are there any more questions for Marie? Nope. Okay. Thank you so much, Marie, for taking your time to come and speak with all of us. We all really appreciate it. We appreciate the fact that you've listened to what our needs are, and hopefully we'll progress forward with improving things in the borough for not just the residents, but for us clinicians as well, for those that are working on the ground. So thank you so much.
Thank you. Take care. I'll leave you to the rest of your meeting. Bye.
Bye. Right, so the next item on the agenda is Dr. Kenny. He's coming to speak to us about Teamnet. Now, I know that a lot of us have been looking for ways sharing information effectively, keeping things up to date, keeping information consistent across practices, across PCNs and different staff levels. And I'm hoping that, Kenny, you're going to help fix this problem, because I think Teamnet is possibly the answer. So over to you, Kenny.
Hi, everybody. Can you hear me?
Yeah, we can hear you fine.
Great. Hi. I know you definitely don't know who I am. I'm a Kenny. I'm a GP in Tower Hamlets, I'm afraid, so not Newham Wood. But I've been asked to come and just have a chat with you guys about Teamnet. I promise I'm not trying to sell anything. It's just something that you guys already have and that we're utilising in Tower Hamlets, I would say slightly differently. So my role is as something called knowledge management lead. Whatever that means, but essentially it is about sharing information. We get a lot of emails, we get a lot of websites and things, and a lot of guidelines flowing around everywhere, and no one remembers them. Quite simply, they don't know what service is up and what's going on and what the current guidelines things or how to refer in. So about 8-9 years ago, we developed a website to do this. That subsequently moved on, and we've now procured something called Teamnet. We figured, well, I'm sharing this stuff with Tower Hamlets anyway, so we might as well share it with Newham because most of the pathways are the same. So I'm not sure how familiar anyone is with Newham. I'm just going to with Teamnet. Sorry, I'm just going to share my screen.
So Kenny, just to come in, you know, all of the practices do have Teamnet, but the level and the extent to which each individual practice is using and individuals within the practice are using is really variable. So I think what the hope is that in Newham that we're all using it in the same way, so that we're getting, I think there's a lot of value to using it in a good way, and I think that's what we're hoping to achieve.
So that is actually a really difficult question. So yeah, I know that you've all got Teamnet, but actually from my understanding, you all use it in a more practice level to do your fridge temperatures, to do your leave, to do your calendars and whatnot and things like that. But actually Teamnet is a lot more than that. In fact, it's too much, in fact. I have not focused on the in-practice usage because quite frankly, I'm a GP. I want to know about the clinical guidance. And so that's what my job is to a degree, is to communicate that and make sure there's all the same information that everyone gets. And we've put it in, we've hung our hat on Teamnet, it's just so happened now. The purpose of this talk, what I've done is I've created a bunch of pages for multiple specialties, but there's one page that's essentially the pathways page. That's guidelines and pathways that have been created by BARTS. So the child and young people's guidelines. There's a whole bunch of PEDS clinical guidelines that are out there that the NEL or BARTS have been asking me to share for ages, and I've been sharing with Tower Hamlets for years, but we can't access Newham or Waltham Forest SN, so this is the opportunity for that. Like I said, I'm just going to share my screen. Tell me when you guys can see the screen.
Yeah, now we can see it.
Good. So if you can see the screen, this is essentially, if you're not familiar, this is the front page of Teamnet. Some of you might be using Clarity as your appraisal kit, okay, if you remember. So I use Clarity as my appraisal toolkit, and I've actually linked it with Teamnet, and I've done that with all the GPs in Tower Hamlets so that you can get CPDs as you're scrolling through Teamnet. So that's an extra bonus function. So we've managed to put this home screen on every computer in Tower Hamlets. So as soon as someone clicks on the computer, this comes up. I think that's useful in terms of engagement and utilization. I always tick remember me on this device. I don't have to keep logging in. This is the front page of Teamnet. I'm currently on a different portal. The whole concept of portals is pretty confusing, and I'm happy to explain it at a different time. But think about different hierarchies of portals, really. You've got one overarching hierarchy which shares information down and to, let's say, networks, and between each network they have their own portal, and then underneath each network portal there's the practice portals. Practice portals can't send information up, but the network can send things down towards the practices. Within your practice portal, you can do whatever you want with it, and it can only be accessible by you, and no one else can see that information. I've been given the access to the Newham CCG portal, this is called, and this is essentially the home page. It will see. First thing I want to highlight is this is the announcements box, which I fill in every so often, so you can see what's up, what's kind of important and new right here. So, for example, quite relevant now is the current list of services that are only on advice and referral. So if you utilize ERS, it's quite difficult to remember or find what services are only advice and referral. So I've summarized that, and this is essentially just a list of what is there and how you can access it, and what so the newest one I've sent out today, which you've actually all should have received an email from me from, possibly. I haven't tested out sending an email out to Newham before, but I did it today. I sent an email out to a link to a Teamnet item, which is actually this announcement to say that there's a PEDS allergy clinic, but on ERS, but actually it's only accessible to Tower Hamlets, and Newham and Wolf Forest still have to go through general PEDS advice and referral, I'm afraid. So that's the announcement. But more useful to you all is probably this Pathways homepage. So every time I update something, it will come up on your homepage in this front, and it will come from something called the CSI TNW portal. CSI stands for, I don't remember why it's called, what it stands for now. Clinical Summary Index, I think we named it at the time. It doesn't really matter what the abbreviation is. And TMW, just Tower Hamlets, Newham and Wolf Forest. And if you click on the Pathways page, what you'll get is the Pathways topics page. And here you'll have a list of all the current guidelines that, as far as I'm concerned, exist in BARTS. So let's go to, you've got individual guidelines here. So you could say, I don't know, diagnostic pathway for patients presenting with respiratory symptoms during COVID-19 pandemic, or yeah, it's a very specific one. Management of patients following postpartum intrauterine conception. I mean, these are pretty vague things that no one's going to remember. But if you click on it, there is a link, and then click on it again, then comes out the guideline, theoretically. I have to say this is not a particularly useful guideline because it's full of text. Normally I would speak to the team and say, can you change this into some sort of flow chart or something, but I was unsuccessful in this case. Something, again, this is the children and young people's one. Sometimes there's pages that's got so much information on, I have to make a separate page for it. So for children and young people's physical health, this is exactly what I've done. This page you'll find what services are available. So apologies, like I said, I have to remember I'm a GP in Tower Hamlets, and this has been commissioned for Tower Hamlets from my point of view, but I'm just sharing this out to Newham, so it is a little bit Tower Hamlets focused. But I'm going to put down every time it's something specific for Tower Hamlets, I'll write down it specifically for Tower Hamlets. I think the whole bunch of contacts for BARTS Health for all London, essentially. And here are all the guidelines that PEDS have been desperate to show you guys. Let's say, I don't know, again, you just click on it really, and then you click on the box, and you'll have the access to those guidelines. These are the ones that BARTS has specifically made, say lymphedema, and that's their flow chart for what happens. Have a child with lymphedema. You might notice that some of this says the item is overdue for review. That was a mistake on my part. I'm the only person that does this, so there's a lot of documents and there's loads of things. I don't have time to go through all of them, and I really optimistically only put a 1-year review date on every single document, and there's like 10,000 of them, so you're gonna have to bear with me on going through reviews of this. But generally I've been doing this for quite a long time, and if there's ever any changes, the clinical lead or the department themselves will contact me directly and I'll update it. So I'm not too worried about, and obviously I'll rely on feedback. If someone tells me something's out of date, then I'll find out and change it. So that's probably the most relevant things for Newham, really, that how to access this Pathways page, and click on whatever ear, nose and throat, PEDS, any of these things. You also have access, of course, to everything else on Teamnet. So say, for example, this clinical support page. But as you can see, yours is completely grayed out because you have no information on there. You might have patient information leaflets from Teamnet. I've disabled all of those for Tower Hamlets. I'm not sure what Newham's done, but because I didn't find them particularly useful, and there was such thing as information overload, so I've disabled them. So you've only got Pathways. I'm not sure, but I suspect you probably don't have too many contacts. There's those things that you haven't populated, and I've added the pathways to my useful links here, which is something that you can do as well if you need to. I mean, it really depends on what all the GPs in Newham want to do with this, or how far you want to go to take it, and what you want me to share, really. I've shared the pathways because that's quick and easy, and that's something you can do. And if there's anything updated that I find out from Nell or Bart, I will announce it and I'll send it over to all of the Newham GPs as well, and that will come up here and here. Sometimes I might send an email out to you, but I very rarely do that because I hate receiving emails generally. And so I'm assuming you guys get overloaded with emails as well. If you, just to give an example, what I've done with us, for example, we've got a few different organizations going to feed in. So the Tower Hamlets Medicines Optimization Team also have their own page. So all their shared care guidance, for example, and antibiotic guidelines are all here, and everything, the transfer of care documents, shared care, like I said, are all here that they deal with, and any medical alerts will be here as well. We also have something, the EBNF Tower Hamlets Formulary, which we have access to through this. If you want, I mean, anyone can, if Druga or anyone tells me that if you want to have access to Medicines Optimization Team, just let me know. I will share that with you, because quite frankly, there's one team now from MO. I think there is no Tower Hamlets anymore. It's Newham, it's Waltham Forest, and it's Tower Hamlets. I haven't done it so far because I don't know where they're going with their page. But if you want to have access to it, I'll give it to you. The other thing that is probably useful is contact, that would be useful for you, all of you, is probably contacts. I don't remember how many I have now. Oh, there you go, 712 contacts. So these are basically a collection of all the phone numbers in Bart's, and also between bypass numbers between practices and community teams, and everything that I could possibly think of was here. Diabetic community nurses, and again, you just search for it here, for example. I don't know. Something comes up. And I spelled diabetes wrong. And yeah, that's everything in a nutshell. This is really there's no meant not to be patronizing, but the Teamnet is really complicated to navigate. I appreciate the interaction, the interface isn't particularly nice, and there's certainly loads of restrictions, but it is a very useful thing to have guidelines and things at a click of a button. And hopefully you find it useful, and if not, I'm happy to take feedback and change it as necessary, really. And if you want more from it, then let me know. Happy for any questions.
Thanks, Kenny. We have got a few hands up and a few questions, but just before we go to the questions, Bhupinder, is there anything else that you want to add from the Newham side? Because I think so even when I'm looking at this on my Teamnet, I don't have access to the Newham CCG portal. So I think that's probably the first question that everybody wants to ask. But just anything else that you want to add, Bhupinder?
I just wanted to say, really glad that Kenny's come over to help us. I've been seeing what Kenny's been doing over the last couple of years and felt quite jealous that Tower Hamlets had funded a GP who just populates this data, all these guidelines. I mean, it's a lot of work, as you can see Kenny's put in over the years. It's impossible to replicate. But because we've got the same priorities with Bart's Trust, it made sense to invite Kenny over. So I've been asking him, and I'm very grateful NHC accepted that offer. And we've already got Teamnet. So he was over the moon to see that all our practices have already got Teamnet logins. We now need to just maximize the opportunity that's now available, but also work out some way of locally authoring stuff, because Kenny does Tower Hamlets. So we'll need some local authors via NHC maybe, and maybe appoint a couple of local leads who can help populate it and make it a bit more local. Thank you.
Thanks, Bhupinder. So is there sort of a quick way where all of the Newham, the clinicians that and the admin that work within Newham are given access to the Newham CCG portal? Because I'm conscious that I think Durga's always happy for us to contact her, but obviously this is going to be thousands of people asking her this query. So is there any sort of quick way that all of us can be added on to with the Newham CCG portal?
Okay, so let me explain that. Sorry, I clearly didn't do that very well. So there are multiple portals. Every practice has their own portal. You don't need to have access to a Newham CCG portal. You just need to have access to your own portal. So for example, I work in the Aberfeldy practice most of the time. So I have access to the Aberfeldy portal, and their homepage will show anything that I've sent down, but also anything that they have deemed to put up themselves. Okay, so and anything that medicine optimization team have put in. So you should all have a login to your own practice portal. If you don't, you just have to ask your practice manager, who I assume is the person, the main administrator for Teamnet, and they will make a password and username for you. As soon as you log in, you will access that homepage, and you will see this. Essentially, this is what you'll see, plus anything else that your practice manager has put on. The Newham CCG portal was kind of future planning, that if the Newham Federation or whoever wanted to drop their own information to use it as a communications tool, which is something that I also use it for, then they could access the Newham CCG portal, and then they can then send an announcement or a library item it's called, or whatever, fill this all out, and then I would then be able to send it. You choose the groups who you send it to, really. Where am I? Sorry, I'm making everyone dizzy by scrolling, but you choose a group, and look here, I can choose to send it to whoever I want, really, all Newham Central member, or the just particular one network. And you can even send, well, I don't have access to sending to individual practices, okay, which makes sense, because I would never need to send it to individual Newham practices. But if you ever wanted to have that, that's something that will be sorted out. And more than that, if I really want to keep on clicking, you can also choose individuals, actually. So if actually nothing bad will happen, I can choose people by role, what I want them to who's received. So you can send, if you're doing this really cleanly as a practice, for example, or even as a network, you can just send information just to clinical staff or just to administration staff. That, I think that is actually important, because it's about information overload, really, isn't it? You know, not everyone needs to read everything all the time, and we need to be quite careful on who sends what to who. Otherwise, people just start missing information because they're just overloaded. So, you know, that's something that can be utilized if you want to. So yeah, so does that answer your question? Sorry, you don't.
Yeah, no, that does. That makes it much clearer. So, Paul, I know that there's other people that have got their hands up, but Paul, can we just come to you first? Because I think you'll be able to give a bit of an insight on what NHC is going to be able to help with this.
Yeah, so I was just speaking with Durga. So in terms of giving everyone access to the Newham CCG, she can load all the staff members in Newham in a sort of single spreadsheet, so everyone has access. So we can organise that next week, and then, as Kenny was showing, we can forward the announcements and the updates to all of the groups and the practices. So what we'll do next week is I'll get Durga to send out an update to all of the practices and individuals, just to let you know that that's now live for everyone. And then,
Paul, just to say, you probably don't want every. I'm assuming you don't mean every single person in staff member in Newham.
No. I think in the first instance it'll be the clinicians and the practice managers, so they've got access to it.
They don't need access to a Newham CCG portal.
They don't.
They don't.
That's right. So
I think now you've showed us that second thing, I think it makes more sense. So we all have access to Teamnet.
Yeah.
We all have access to the information on Teamnet, but somebody centrally has to send out the information so that everybody that's logged on to a Newham practice login that's affiliated with Teamnet has the information. So when I log on to mine, I can see the same 4 announcements that are on Kenny's homepage. Absolutely. And then I've got an update on the Pathways homepage from where it says updates from CSI TNW. So if we've got somebody that's sending out that information, so that could be Durga sending that out, or somebody else that's allocated that role, that other person will keep everybody up to date with all that information. But it's about, I think what we need to look at is, how are we going to do it in a systematic way so that it's the right information going to the right people and not everybody getting everything, because then it defeats the purpose of keeping it streamlined and effective.
Yeah, Arpana, that's absolutely right. And the only people who need access to the Newham CCG level are the authors, the people who they should change or add information. So we need to make a list of authors, as you said, a systematic way of doing it, so we all know who to go to make changes or add things to.
Okay, so Kenny, there's lots of hands up for questions, so we'll go to Laura first.
Just very quickly, again, like Bhupendra, I'm just very jealous that we don't have a Kenny. And I would hope that, you know, we are able to coordinate it like they do in Tower Hamlets. And if NHC are funding Teamnet for the practices, if they can also fund this coordination, it's very, very, very important.
Thanks, Laura. And then Wax.
Oh, thanks, Kenny. It's really good that you opened up our eyes, as it were. That's really, really helpful. So we're using Agilio quite a lot. Yes, links to appraisals and stuff. But I just wanted to understand your experience on some other things. So when I was looking through secretly into what you were doing on your screen, I couldn't see any practice policies on there. So how have you found using it for things like practice policies? I don't know, your call to call or your whistleblowing or your fridge checks, etc. and stuff like that, because you did mention it was quite clunky. So it'd be good to get some of that, understand some of that early learning or the learning that you've had for things that maybe didn't work on there before we kind of embark full scale into this kind of new way of working.
I'm afraid I'm not going to be able to help you there. I purely focused on clinical information. My interest it lies in being able to effectively share communication, and we deliberately have not pushed it in practices to kind of dump all their already existing software and whatever they're using previously to upload onto Teamnet, because I didn't want to be the one to make that decision. You can use it; it's up to you to use. But I would say that it's not a bad Teamnet is not a bad thing. It is a good thing. It actually is very useful, really useful. And the CQC documents and the tracking things, if we can get that up and running, everyone can share their CQC documents. That's going to be amazing. And so I would say play with it and use it. And in fact, I'm talking to my current practice manager to say maybe we should use it. It is the problems I face with Teamnet are not so much on a local small like a practice level. It's more that I've got way too much information and I'm just sending this and it's just too hard to search for. But other than that, you know, it's a useful. It's good. It's pretty straightforward, really.
So if I could answer that, Wax. Newham NHC has paid for very high level access for everybody to have Teamnet, and in the first year we had it, or 2 years, to be honest with you, I wasn't very impressed with it. But in the last 18 months, we've started to use it quite significantly, and it's been a complete game changer on a number of levels. It allows you to do the recording. I think now it's going to make our CQC inspection half the work it was before. Especially with the online courses that they give us, which are really much easier rather than the 1 or 2 hours per course. You can do most of them in 20 minutes, half an hour. And we've got better compliance now. That's another conversation. Whilst Kenny is here, what I would like people to take answers to questions for is to focus on all this hard work and not get distracted down a conversation of Teamnet, yes or no, if that's okay, Chair, if you don't mind focusing on that.
Thanks, Kenny, for being honest. Thank you.
Okay, so we've got 2 more hands up, Salma and Manuel. Then, Kenny, if there's any other questions, we can ask people to write them in the chat bar, and if you can respond there. Yes, so Salma.
Hi, I just wanted to, you know, Teamnet, we've been using it. So if NHC were to give passwords, I think they need to speak to each practice before they send them out again, because we're already signed on. I actually wanted to ask doctors a question about if we're allowed to have policies on there. It's actually very good for policies. We put policies on there. We also keep our maintenance logs on there. So it's actually used for a lot of things that you can. And the 2 systems you can see on it is you can see your PCN and you can see your practice as well. So I just wanted to answer the questions for that.
Thanks, Salma.
All right.
Manuel?
Just to add on to what Salma said and what the doctor said is that this could be actually your practice portal. You can manage HR, you can manage absence management, you can manage the CQC, and also you can actually link most of your CQC to key line of inquiry and also standards as well. So it's got a huge potential. So I think we need to actually have a look at the potential of this Teamnet entirely. Because I've done this before, so from my own experience, so I can recommend that we can do that. And also you can actually create barcodes. So example, if you have a primary and secondary reading for your fridge temperature, you can actually create barcodes and you can use your smartphone to scan it and enter on there and then your readings. And doctor's bag, the emergency drugs within the practice, individual rooms, emergency drugs in the individual rooms. So it's massive. So just not from a clinical point of view, just from an overall practice management point of view, clinical and administrative governance, CQC likes this as well. Significant event analysis, your complaints, risk management, you're managing your premises like your weekly alarms and stuff like that. You can, it's endless. Okay, so yeah, I just want to add that to you.
Great, thanks, Manuel. Okay, thanks a lot, everybody. Kenny, thank you so much for sharing what you've done in Tower Hamlets, and I'm hoping that we'll be able to replicate it to the same level in Newham.
Before Kenny goes and everybody moves on, can we have a little meeting in NHC to discuss who might be the local authors? Arpana, your suggestion, that would be really helpful.
Yeah, definitely, we can set that up.
That'd be great. Thank you very much for your support, and thank you very much, Kenny. I'm so happy.
Thanks a lot, Kenny.
Look, and you can always feed back to me if someone's missing. You just click on the feedback button on the whatever item, and it pops over to me anyway. And I'll take it if I can fix it. If so. And Bipinda, drop me an email, and happy to help if needed. In terms of engagement and the help of all the GPs to make it up to date is really important. I think constant feedback is really important.
Brilliant. Thank you so much, Kenny.
Thanks, Mark. Bye.
Bye. Okay. Robin, sorry, we're running a bit behind as usual when it's on my watch. So we've got Robin here to talk to us about the Newham Autism Diagnostic Service. And I know that a lot of us have had adults coming to see us either seeking a diagnosis or just assistance with autism. And unfortunately, we've not had anything that's been within the borough. So at times we're having to send patients out of borough. So it's really good to hear that this diagnostic service is available for us. So Robin, can I pass over to you?
Yeah, absolutely. I mean, I'll keep it quite brief. I know I think I've presented to a few of you before about this, but it's always good to give an update because things are moving quite fast. So yep, this is for me. I'm here to talk about the Newham Autism Diagnostic Service, which sits under the governance umbrella of the Newham Health Team for Adults with Learning Disabilities. If we go on to the next slide, that'd be great. And the next slide, actually, I don't need to tell you what autism spectrum disorder is. Just very briefly, so I suppose here I've just put a few lines around what the rationale. Why do we assess adults with autism? I won't read through all of this, obviously, but I think one of the main issues here is to help people to get access to appropriate services and benefits, and to help people join an autism community or a wider neurodiversity community, to help them understand their diagnosis and to think about some of the help that not only our service but other services might help them in terms of reasonable adjustments, moving on with their lives. If we go on to the next slide. So the overarching aims of the service at the moment are to obviously develop a clear pathway for diagnosis, increase awareness and understanding of autism, and within that promote rights to independence, but also to support local partners to develop services for autism adults. And what we've already started doing, obviously, because there hasn't been a real autism presence in Borough in terms of a diagnostic service, we've found that obviously there isn't in regards to the third sector, in support networks and systems for people with autism, there isn't much of a presence in Newham. So we've been talking to various providers about thinking how we can start to kind of encourage people to invest in Newham, to think about services that might be available in terms of helping people to get better access to employment and education, but also acknowledge that some people require more than just peer group support, and actually require more kind of in-depth one-to-one support, especially if we're thinking about issues around travel training and kind of meaningful engagement with employment, so those sort of things. So we're just kind of scratching the surface at the moment to try and find out what's already out there and what kind of services we think we'd like to kind of engage with to encourage them to come into Newham in the future. If we could go on to the next slide. So this is a kind of brief description of the team. It's an MDT, and currently this is our quorum. So obviously we have a consultant psychiatrist, an operational lead who will also be a senior practitioner, and also 2 senior practitioners and admin. Just to say, we are interviewing for the team administration post next week, and I know that there's some background stuff going on around the consultant psychiatrist, but we've recruited to the operational lead and the 2 specialist practitioner posts, and 2 of those people are actually already in post and are currently triaging the existing waiting list. So even though we haven't actually gone live, we do actually within the last week have 2 of the practitioners have already started, and they're already starting to go through the referrals that you've been sending us to kind of screen them and see whether any further information is required. So we envisage that actually they'll start doing the formal autism assessments, I would say, by month's end. So hopefully by the end of November, we'll actually start seeing people face to face. The service is going to be based at the Lord Lister Health Centre on the 1st floor. And we're doing some work with estates there to make sure that this environment is autism friendly. And by that, I mean that we're for the rooms where people will be assessed and the waiting rooms where we're putting in dimmer switches to kind of make sure that we can regulate the lighting. We're also looking at things like room temperature, even the color that the walls have been painted and things like that. And we've been engaging with Newham residents who have a lived experience of autism, not only to be part of our interview panels, but also helping us to think about service design to make sure that we get it right, and that this is a therapeutic environment where we hope that people with autism will be able to kind of engage meaningfully as part of this assessment process. Yeah, so if we go on to the next slide. So just a bit about referrals. So referrals to the service can be made by GPs, NHS consultants, and liaison and diversion services. And I'm happy to obviously send out the referral form again as part of this meeting. I notice at the bottom you've got please email referrals to, and a bit of the address is missing. So when I send out the referral form, the Dropbox address that you send them to is at the bottom of that. So yeah, hopefully it's pretty straightforward. We do ask for quite a bit of information, And I would please ask that you try and fill as much as you can, because this really informs us. Not only, it helps us to kind of limit the amount of triage we have to do, but also it helps us to think at that referral process, are there any other services that we could be referring these individuals to while they're on the waiting list, waiting to be seen by our service? Just to add, as part of the autism diagnostic assessment, we'll also be doing ADHD screens as well, because we understand that obviously there is a comorbidity there between ADHD and autism. I think it's around about 40%. So we do understand that there is a very good chance there'll be a lot of knock-on referrals to the ADHD service. So we've decided that we'll actually do the ADHD screens there as well, just to make sure people are sent to the right place in a timely fashion. The waiting list at the moment's growing. We started the waiting list in July. I think it's now around about 80 people. So it's beginning to, hopefully it kind of shows you that there's people have been waiting for this service. But yeah, the waiting list is growing quite rapidly. So we're hoping that by, as I say, within the next 10 days, we should start to crack into that, and hopefully we'll be in touch with referrers in the near future to let you know about outcomes. So yeah, was there any questions at all?
Thanks so much, Robin. I have one question.
Sure.
Because obviously you've highlighted that you will probably receive large numbers of referrals because we've been waiting for this for such a long time.
Yeah.
Is there a referral form that has sort of, like a checklist or things that you would like them?
I'll send that round to this group. It does ask questions around things like, developmental history. It does talk about the person's experience and why they feel they may be autistic. But at the end of the referral form, there is also an AQ10, which is a kind of pre-referral questionnaire, which also helps us to kind of understand better the individual's strengths but deficits as well, when we're going through that kind of triage process. So I will send that out again to you outside this meeting, and if you could circulate that, that'd be great. And also we obviously want to get this referral form embedded onto EMIS as well, so you'll have easier access for GPs.
Okay, great. Thanks, Robin. We've got a question from Laura.
Hi, Laura.
Hi, Robin. Thanks so much for presenting.
It's okay.
Just a question about obviously the referral criteria, and I think it's obviously for a certain subset of the patients that you're now taking on, they have to have, I think I'm correct in saying, please correct me if I'm wrong, certain things like ECGs and TFT in case they're started on medication. But it's just... Sorry,
did you say ECGs? They need to have had an ECG or...
Yeah, I think I'm correct for the...
No, they don't. Not for the autism referrals.
Are you covering that aspect as well? Because am I correct in saying that it's going to be covering both areas?
Autism and ADHD, did you say?
Correct, yeah.
No, we're not. We're not an ADHD service. Sorry, I may have been misunderstood. When they come to us for the autism assessment, we will also screen for ADHD, but we are not the ADHD service. Sorry, yeah, it's just to say that because there is that strong correlation between autism and ADHD, we felt it would be appropriate for us to screen, but we're not actually the service that will be doing those assessments.
So it's not this service that asks, because for example, I think there is a local service that for ADHD
there
now.
Is, yeah.
And they do ask for ECG
they
and TFT
do, yeah,
before
yeah.
even. So I guess I'll just have to direct it to that team because
we don't know.
Okay.
We are engaging with them at the moment because any new service is going to create a real ripple across the system. And I think this service is going to have a massive impact on the ADHD clinic, but also the autism social workers. In this borough, there is one. So we're also working with the local authority to talk about, look, we've got to be ready. We've been waiting for this service. It's going to create, a lot of requests for benefits assessments, for ADHD, for all sorts. So, it's going to have a ripple effect, and we're trying to work out at the moment exactly where those where that impact might be. But for us, we don't need any of that.
Thank you, Robin.
Thanks, Robin, so much for that, and we look forward to seeing the referral form. And if there's anything in terms of, for example, say if GPs or clinicians are making referrals that you feel or your team feel that may be inappropriate, please do feed that back to us.
Yeah,
because
absolutely
I think that
right.
will help with the service as well.
We will, and I mean, I think what we've also got here as well is, the people in this service. I mean, we've been really fortunate based on the challenges with NHS recruitment at the moment. We've managed to pull together a really experienced team of people that all come with experience of working for previous autism diagnostic teams. They are a wealth of information. They're a really good training resource as well. So if in the future anybody's interested in some more bespoke training, please let us know, because yeah, we've got something there that I think we could really utilise to spread the message across Newham and really educate people as well.
Brilliant, that sounds good. So I think that is something that we can look to do at a later date.
Brilliant.
Okay, thanks so much, Robin.
No problem. All right, thanks a lot. Bye.
Bye-bye. Right, thanks everybody. Is there any other question, business, any comments from anybody else? Nope. Okay, so I just want to take this opportunity to thank everybody. This is our last meeting of the year from NHC. So on behalf of NHC, thank you to everybody for your support. We appreciate everybody's hard work, and wishing everybody season's greetings, a happy new year, and we'll see you now in January for our next meeting. Okay, take care, everybody.
Bye all.
Aparna, we're here.
Hi.
Thank you. We thought there was a December one.
I asked Karen this morning. She said no.
Did she?
Did she? Oh.
Okay.
That's why I asked.
Okay.
For those of you
All right,
still on, I might have made an error.
No,
In
no,
which
it's
case
okay. It's
we will
okay.
kill you earlier.
Yeah, we'll find out later. It's okay. It's fine.